I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Hi everyone, and welcome to the first PRS Journal Club podcast for 2018. My name is Francesco Egro, PRS Resident Ambassador from the University of Pittsburgh Medical Center, and I'm joined by my co-residence ambassadors Ira Savetsky from NYU and Nicole Phillips from the Harvard Plastic Surgery Program. I want to take the opportunity to thank the incredible work done by last year's residence ambassadors, Jordan Fry, Chad Purnell, and Shuja Shafkat. Thank you so much for your amazing work and for an outstanding year. Today we have the great honor of being joined by Dr. Bernard Lee as our guest moderator. Dr. Lee is Professor of Surgery at Harvard Medical School, Chief of the Division of Plastic and Reconstructive Surgery at Beth Deaconess Medical Center, and co-director of the Peter J. Sharp Program for Aesthetic and Reconstructive Breast Surgery at BIDMC. Thank you so much, Dr. Lee, for joining us for this PRS Journal Club podcast. The article we'll be discussing is the expanded use of autoaugmentation techniques in oncoplastic breast surgery by Drs. Losken, Hart, Broca, Dutton, Stablo, and Dr. Carlson from Emory University in Atlanta. A quick reminder that this article, along all of the articles that are discussed in this podcast, can be read for free on prsjournal.com, including an archive of all past Journal Club articles. As we know, oncoplastic reduction techniques have become an established approach to reconstruct partial mastectomy defects in women with macromastia. The procedure has become more popular, has been refined, and the indications for its use have been now broadened thanks to the fantastic work of many pioneers, among which the Emory Group who wrote this paper. The oncoplastic approach is now being used for large tumors, higher cancer stage, and in conjunction with intraoperative radiation therapy. With this expansion, autoaugmentation techniques have been adopted to assist with these challenging cases, and the authors in this paper sought to determine the indications of oncoplastic autoaugmentation techniques and compare the outcomes with traditional oncoplastic reduction techniques. By querying a prospectively maintained database of all women who underwent partial mastectomy and oncoplastic reduction between 1994 and 2015. They examined and compared the demographics, tumor details, and surgical techniques and outcomes of three oncoplastic techniques. First, the traditional oncoplastic reduction technique, where the defect was filled with the nipple pedicle and or the residual breast tissue. Second technique was the extended primary nipple autoaugmentation pedicle, and the defect was filled by extending the primary nipple areola pedicle and rotating this into the defect. And the third technique was the use of primary nipple pedicle and secondary autoaugmentation pedicle, where the nipple pedicle was used to reposition the nipple and a secondary independent dermatoglandular pedicle was used to fill the defect. Then a comparison was made between the groups to determine first which breast size and tumor location required what reconstructive technique, and second whether the autoaugmentation techniques were associated with an increased risk of complications. The cohort was made up of 333 patients, of which 222 underwent a traditional oncoplastic reduction, 51 patients underwent an extended autoaugmentation pedicle, and 60 patients underwent a secondary autoaugmentation pedicle. Patients in the secondary pedicle group were significantly older, with a mean age of 59 years, whereas the extended pedicle group had a significantly lower BMI, with a mean BMI of 30. Compared to the other two groups. Otherwise, there were no significant differences in the other demographic variables. The lumpectomy weight was smallest in the extended pedicle group with a mean of 136 grams and largest in the traditional oncoplastic group with a mean of 235 grams. And in terms of pedicles used, the superior medial was the most common extended pedicle used and most common for lateral defects, whereas the inferolateral was the most common secondary pedicle for lateral and upper outer defects. As one might expect, the average breast size in women that required autoaugmentation techniques was smaller than those that did not, and with women with contralateral weight specimens less than 300 grams undergoing an extended pedicle more frequently. But interestingly, there were no statistically significant difference in the overall complication rate between the three groups, with approximately 15% in traditional oncoplastic group, approximately 20% in the extended pedicle group, and 20% in the secondary pedicle group. and the rate of completion mastectomy was 10%, which was also similar among all the three groups. In terms of what I thought of the paper, I thought this was a very good paper, and I thoroughly enjoyed it because it truly exemplifies how oncoplastic surgery is evolving and how the Emory group has been spearheading and spreading these innovative techniques. The take-home message for me of this paper is that autoaugmentation techniques are safe and effective in its ability to fill larger and more difficult defects without increased risks of complication. They should be considered, according to the authors, in patients with smaller breasts who still want to undergo breast conservation therapy, or patients with large breasts where the defect is either too large, too remote, or there is not enough nearby parenchyma available to fill the tumor cavity. And specifically, the authors suggest to use the extended autoaugmentation technique for medial, lateral, or upper defects, especially in women with smaller breasts, whereas the secondary pedicle, they recommend to use it for lateral or medial defects. And the authors provided some true pearls for inexperienced surgeons like myself. For example, the importance of flap length and width, minimizing the amount of pedicle undermining, and deepithelializing more when concerned, which they said will improve flap perfusion. And lastly, I'm glad the authors included an algorithm to guide us through the decision-making and type of oncoplastic technique to be employed based on breast size and defect location. I hope that in the future, the authors also assess the aesthetic outcomes and patient satisfaction to provide a full picture of this evolving field. And I wonder how the increased amount of cutting and dissection affects breast screening from a radiological standpoint, which obviously is an important concern and area that requires further research. Dr. Lee, the authors state that these autoaugmentation techniques described here are useful when the defect is larger and more remote, or there is not enough nearby parenchyma available to fill the tumor cavity. While they have showed that this is a viable and safe option, my concern is how to shift the mindset of breast surgeons to become more welcoming of these techniques. How much convincing do plastic surgeons have to do, and how hard will it be to get the breast surgeons on board? What are your thoughts?
I think the first piece is that anytime we're talking about reconstruction of oncologic defects, a communication pattern has to be established between the oncologic surgeon and the reconstructive surgeon. Nowhere is this more important than in breast surgery. I think breast surgeons often think of plastic surgeons for reconstruction of mastectomy defects, but more and more the shift has become oncoplastic surgery and reconstruction of lumpectomy defects. With this shift, there has to be a good discussion with the breast surgeons in terms of planning, how the surgery should be done, what patients are good candidates for this type of surgery, and the intraoperative details in the technique. At our institution, we've been performing more and more of this type of reconstruction, oncoplastic surgery. And with that, there's a learning curve involved in terms of the discussion both with the patient and the breast surgical oncologist in terms of determining which patients are the best candidates for this types of procedures. And so the question is, how much convincing do we have to do and how hard will it be? Well, the reality is that with improved outcomes, breast surgeons will be sending us more patients for this type of surgery, because the defects from a lumpectomy without an oncoplastic reconstruction can often be extremely disfiguring.
Absolutely. But I feel that in certain centers, some breast surgeons, they feel that not all lumpectomy patients should have a discussion with plastic surgeons for the reconstruction. And that's where perhaps the educating factor might be very relevant and a very important factor, so that at least they appreciate that it's not just either lumpectomy or basic oncoplastic reduction mammoplasty, but there are alternatives. And so I really appreciate your comments. What are your thoughts, Nikki, of this paper?
I thought this was an interesting paper presenting some, new and different techniques to consider when looking at patients who are reasonable candidates for oncoplastic reconstruction. I think, as we've already been discussing, it's such a multidisciplinary topic, and it's not only the breast surgeons and the plastic surgeons who are involved, but I think there also has to be buy-in from radiology and pathology, because these are going to be people who are also helping to track disease over time and help us make decisions about management. Dr. Lee, I'm curious to know if there are patients that you think are just not appropriate oncoplastic reconstruction patients, or if there are patients that you think are better suited to it.
I think most people are familiar with oncoplastic reductions. So in the early series, performing a breast reduction in conjunction with oncoplastic surgery or a lumpectomy probably makes the most sense in improving outcomes and overall long-term aesthetic result and patient satisfaction. There are patients where an oncoplastic procedure may not be indicated. In patients that have multifocal disease, large tumors, a long discussion probably has to be had with the breast surgeon and the patient as to whether or not this is the right procedure. In certain patients, a mastectomy may be a better option with alternate type of reconstructive surgery.
Yeah, I think certainly, again, this sort of just keeps on being a theme here is, that we have to have a lot of discussion between our patients and our colleagues to make sure that these are the appropriate surgeries to be offering. And so thank you very much for your thoughts on that. Ira, what did you think about this paper?
I thought this was an excellent and very thorough paper. As Francesco mentioned, I particularly like the operative pearls and algorithm, which I find quite useful for myself given my current level of training and experience. And as we have already mentioned, this paper highlights the importance of patient education and communication between multiple disciplines. My question for you, Dr. Lee, is if you're performing a symmetrizing procedure to the contralateral breast, are you doing this in 1 or 2 stages? And if you're doing it in 1 stage and the patient is to go on and have radiation therapy, what are some of your techniques to account for the effects of radiation?
In general, I perform surgery on the contralateral breast at the same time, so I don't stage the procedures. As for how to provide symmetry and size, in general, the cancer side that's having the oncoplastic surgery, I'll leave that side slightly larger than the contralateral side, knowing that radiation therapy has a high degree of scarring and potential fibrosis in the future. I always tell patients that there may be a need for secondary revisions of both the oncoplastic side or the contralateral breast in the future to provide optimal results. And when we look at these patients long term, the fibrosis and scarring in the radiated breast is maximal at about 3 years. And so secondary revisions, although we like to do that before that time, there can be further changes in the breast size and composition of the radiated breast up to 3 years after surgery, after radiation actually.
That's a really great point, and that's interesting about the effect of radiation could be seen so far out. Thank you so much for your comments.
Dr. Lee, the paper states that there's a completion mastectomy rate of 10%. And I mean, these are figures that you can find in other papers in the literature. And many surgeons, including some of my bosses, are discouraged from oncoplastic techniques because of the rate of recurrence and the eventual need of completion mastectomy. What are your views about an oncoplastic approach, and what kind of discussion do you have with your patients about it?
I think one of the issues with lumpectomy in general is the margins and whether adequate margins are taken and whether or not a secondary lumpectomy is needed if the margins are still positive. I think one of the main advantages of providing an oncoplastic reconstruction is that we allow the breast surgeons to potentially remove larger areas that we can fill with these secondary flaps, whether it's the primary pedicle or extended pedicle or even the secondary pedicle that the authors describe here in this paper. And with their ability to remove larger amounts of tissue, they can more assuredly have control of the margins, and that allows us to have a better aesthetic result long term. As for the mastectomy rate, I think this 10% completion mastectomy rate is a known sequelae of performing a lumpectomy. And I think there has to be an honest discussion with the patients preoperatively that from the oncology side of things, it is possible that a lumpectomy may not be able to treat the disease and a mastectomy may be required. And this discussion needs to be had from both the reconstructive surgeon as well as the breast oncologist.
Thank you, Dr. Lee. I'm jotting down all these great points. I would like to thank you. Thanks everyone for a phenomenal podcast. And I think with that, we'll end our discussion of this article. Remember to tune in to the other 2 articles we will be discussing on this month's podcast, as well as the PRS Journal Club podcast that will be broadcast every month. Also, don't forget to participate in our monthly PRS Journal Club on Facebook, where we will be able to interact directly with this month's selected articles' authors. And once again, thank you so much, Dr. Lee, for joining us on our first podcast of the year.
Thank you for having me.